Alrighty, so this is going to be the module 6 of the mental health review recording. So we're going to try and tackle the mood disorders. So it's going to be a lot of your depression and your bipolar disorder and everything in between. So with that, we're going to go ahead and start. Alrighty. So with clients that have mood disorders, our main concern is going to be suicide risk. And we'll go into that a little bit more in a little bit as well. So, can I add people? So what we're going to go ahead and first we need to distinguish our types of depressive disorders. So just a general depressive disorder is characterized by persistent depressed mood or loss of interest in activities, which cause significant impairment in daily life, with at least 4 to 5 other symptoms such as anhedonia, which we talked about in our mental health schizophrenia lecture, inability to feel pleasure, changes in weight, sleep and energy, concentration, decision-making, self-esteem, and goals. A lot of our depressive clients, they're going to feel kind of isolated, and they're not going to have a lot of energy to do things. They're not going to have pleasure in life. And because of that, a lot of our depressive clients, that's why they're going to feel like they are not worth it anymore, and they're going to end up suiciding. However, a lot of our depressive clients, they take their medication. They take whatever their SSRI, TCA, MAOI, SNRI, and once they gain that energy, that's going to be the time that they commit suicide if they decide to go forward with it, because they have the energy to do so. Without the medications for depressive disorders, they're going to have no energy. They're going to lack energy. It's called anhedonia, I think. Yeah. But that's just something to bring up as well. So we need to distinguish the types of depressive disorders. So MDD, major depressive disorder. So this patient has persistent depressive episodes lasting a minimum of 2 weeks to 5 to 6 months. So let me see. Let's just say Alex. She is depressed for 2 weeks straight each month, then she would qualify for depression. Let me just pop it. Please see. Many people who have MDD usually have a recurrence in the first year, and most will have one in their lifetime. So meaning, if they have MDD, they're probably going to have a relapse or exacerbation of the depression. They're going to feel sad, empty, and hopeless. They're going to not have pleasure in things. They may be staying up all night, or they may be sleeping all day. They're going to have slow movements. They're going to be irritable. Maybe they might be tired, no energy. They're not going to be able to make higher level decisions. They're not going to be able to make choices. They're going to want to die. Distress.
That's how I feel now.
What's up?
I said that's how I feel now with all these exams.
It might be just a stress depressive. I don't think that you have depressive disorder, Cece.
Yeah, I know.
I don't think you qualify. You might have maybe a brief depressive episode or some just persistent sadness and stress, but
I was joking.
yeah, that's
Sounds
not you. I know
familiar.
that's not you.
Yeah.
Not to brag on her, but this is being recorded, by the way.
Oh, sorry.
No, but that's a good example. So, being a nursing student does not mean you have major depressive disorder. That does not mean that you have it. It's possible you can have it, but because you're stressed, because you're feeling like your hopelessness, let me tell you something, it's probably going to go away. But these people, they're having these episodes like every single day for 5 to 6, for at least 2 weeks. And yeah. And with all these characteristics. We can also explore MDD with psychosis as well, especially with our schizoaffective disorder and with postpartum onset, which we'll go into as well. Postpartum depression is very common with our clients who are pregnant. So you'll learn more about that in maternal child. A lot of our mamas here, y'all might have experienced that postpartum depression. I don't know, I can't relate, but probably have. I mean, I don't know. So, seasonal affective disorder occurs when there is a form of depression that occurs seasonally. Usually, it's going to be in the wintertime because of the climate change. It's going to be they're going to get darker earlier, and because of this, we need to treat seasonal affective disorder with light therapy. So, going to sit in front of like a light. So, yep. Persistent depressive disorder. So, this is not MDD. So, a major feature of this is going to be they're going to have a chronically depressed mood for most of the days and more days for at least 2 years. Usually it's going to be in our younger children. Early onset, before age 21, late onset, 21 or older. Persistent depressive disorder. How I kind of think about it is that the depression is going to persist for a long time and for most of the days. That's how I remember it. Well, it's major. It's kind of like a major abrupt thing. So that's how I think about it. And then premenstrual dysphoric disorder. So this is not your typical PMS. This is going to be PMS on steroids. So these people who have premenstrual dysphoric disorder, they're going to have very, very labile mood. They're going to be very irritable. They're going to be depressed. They're going to be anxious. They're going to feel overwhelmed and difficulty concentrating. Usually it's going to be a week prior to menses, but this PMDD is going to happen at every menses. Not just the first menses. These people are going to be not able to get out of bed a week before their period. They're going to be bedbound. They're going to not be able to do much of anything. But then once they get off their period, they're going to be just fine. That's different than PMS because PMS symptoms, these people can function with PMS symptoms. This is not PMS. Because, I have PMS, you have PMS, but we can still function on that. These people, they absolutely, can't function in life. And that's the difference. These people are not able to function with PMDD. People with PMS can't function. So that's the difference. I was just told about the difference earlier. So, very important to know about that. PMDD does not equal PMS. Although, we all said it equaled PMS, but it's absolutely worse than PMS. So, any questions about that? This wasn't something that was in lecture, but I've heard this previously. So now we're going to move on to the phases of depression. So it's very important to know these because we need to know how to distinguish how the client is working in each stage. So your acute phase is going to be about 6 to 12 weeks. This is when they're going to have the severe clinical findings of depression. They're going to be the most suicidal here. We need to make sure that we have safety precautions. They may need one-to-one observation. They may need to have their environment cleared. They may need to assist to the bathroom. And the goal is to reduce that depression manifestation. We want to make sure that we encourage them to go to group. We need to assist them with their functioning. What else do we need to do? We need to ensure they get adequate nutrition. A lot of our patients that are depressive, they're not eating. They might be malnourished because they don't have the energy to eat, and they don't have the energy to feed themselves. So we need to make sure they get adequate nutrition. Safety is a big concern as well. We need to make sure we get them to group. We need to make sure that we have set limits and have a structured environment for them to function in. And always use therapeutic communication with these clients. Continuation phase is they're able to function outside of the hospital. They're no longer suicidal, and the goal is to make sure that they maintain their medication usage and they don't have a relapse. They need to make sure that they go see their psychiatrist, go to their group therapy, go to support groups, take their medicine, be active in their community. Do the things that they love. Get out of that room. Get out of the bed. Take care of themselves. Maybe get themselves groomed. Maybe go to the nail salon. I don't know. But it's all about increasing ability to function and not going back into those depression feelings. Maintenance phase is when we're preventing future depressive episodes. So we want to make sure that they go to their provider's appointments, make sure they follow up, take their meds, have that support system, go to therapy, yada yada. Alrighty, so risk factors. So genetics supports depressive disorders. Neurotransmitters abnormalities may actually occur, and they're going to be with serotonin, norepinephrine, and dopamine. Remember, a lot of our medications for depression work on these receptors. So, hint, hint. So serotonin helps sleep appetite, norepinephrine, attitude and behavior, acetylcholine, cholinesterase transmitters. But just remember that there's going to be a lot of deficits here. Remember, with our SSRIs, patients who need SSRIs, they probably have lower levels of serotonin in their brain. Because you know what? They have lower levels in those synapses. Because you know what an SSRI does? Inhibits reuptake, meaning it's increasing more in the synapse, making them happier. So that's kind of how I think about it. And of course, it can be because of medications, neurological disorders, electrolyte disturbances. Remember, one can become depressed, no energy from not having enough fluids, hormones, nutritional differences. Again, a lot of your psychiatric concerns are going to be not just like one cause. It's going to be a variety of causes. Now we have transient depression. So transient depression is they have symptoms that are not dysfunctional, but maybe typical human responses that accomplish disappointing things in life. It'll subside quickly, and they may be able to refocus on other goals and achievement. So Cece, I know that you mentioned earlier that you're feeling that you're sad and hopeless because of school. Maybe instead of having major depression, maybe you have a little bit of transient depression. Because your symptoms are probably going to subside quickly. Yeah, you might feel sadness, being downhearted, having the blues, some crying, some stress, tiredness. But let me tell you something. You might, after this quarter, feel a little bit better about yourself. Maybe you might feel a little happier. I don't know. I mean, I could say I don't want to predict the future, but this is just a really good example. I hopefully, well, that too. And I'll encourage yourself, bring up your self-esteem. Because of a lot of our depressive patients, they're going to have lower self-esteem. And that's also one thing we need to focus on, finding their strengths and positives in life. So mild depression is going to be similar to those with uncomplicated grieving. They might have denial of feelings, anger, tearfulness, occupation with loss. This might be a lot, mild depression might be seen a lot with your losses. Because yes, you might lose your loved one and you might be depressed, but this depression is probably going to resolve. I mean, there's a portion that's not going to resolve, but mild depression and transient depression, they're going to resolve. Alrighty, so one scale that you can do is your HDRS. We've already went over that. Hold on, I'm going to pull up some more that she had on her website. Or I might just read off the CI. So I want to make sure that we get those interventions for depression. Yeah. Okay, we went over those. Oh yeah, we need to go over the psychosocial theories. So psychoanalytic theory is based on Freud's perception of the unconscious. Let me see if I can do this. I'm pulling something up real quick, so I'll be right back. Because I know that she definitely talked about those in lecture. What are we next? It's not in here. Oops, I meant to put. See if I can find it in this. Pardon me, I have so much on my plate. So many stuff. I'm like, where is this? I know I put it in here somewhere. Okay, so psychoanalytic theory is developed by Freud to explain personality, motivation, and mental disorders, which focuses on the unconscious. So maybe their depressive manifestations are been brought on by the unconscious mind. Learning theory is based on the ideas that changes in behavior result more from experience and less from personality or how we think or feel about a situation. For example, our learned helplessness with a lack of control over life's events might be why one develops depression, because they know in every situation they're going to feel helpless because that's how they've learned from the past. Object loss theory is when there's a depressive illness that occurs from having separation or abandonment by a significant other during the first 6 months of life. For example, a lot of our foster babies or adopted babies may actually suffer from object loss theory because they're away from their parents or significant other for 6 months, and it can be hard on them. So that might be why a reason they develop depression. Cognitive theory is when there's the primary disturbance is cognitive rather than affective, and the cause of depression is cognitive distortion, which results in negative, defeated attitudes. Here with cognitive theory, our goal is to be reshaping those thoughts into positive attributions, therefore helping the patient go out of the depressive state. And then the transactional model recognizes the combined effects of genetic, biochemical, and psychosocial influences on individual susceptibility to depression. I wanted to make sure I go over those because she said that those were going to be on there. One thing that we absolutely have to do with the patient that is going through a depressive episode is provide suicide precautions. Our number one focus with the patient with depression is to make sure they don't kill themselves, and safety is the number one thing. Remember, we want to do our suicide assessment. Remember, harming, ever felt like life is worth living. One thing I wanted to bring up was covert and overt statements. We didn't talk about these in class, but they will be on ATI for sure. 100% guarantee you. But covert and overt statements, they can relate to depression. So covert statements. So covert statements are going to be like, it's okay now, everything will be fine, it won't be a problem much longer, nothing feels good and never will again. I want to give my body to medical science. So covert statements. Sorry, I'm finding a chapter on this. Management. So another one that's just like, there's no reason for me to go on living. And then covert would be, everything's looking pretty grim for me. It's kind of like covering it up. Overt statements is kind of like those like I wish you were dead. I'd be better off if I died. Life isn't living anymore. I can't take it anymore. Covert's kind of like covering it up. Well, overt, it's like you're over exaggerating that you're not feeling like you want to live anymore. So that was one thing I wanted to bring up because we did not go over that in class. But I know it's going to definitely be on ATI. Alrighty, so here's that suicide. Again, we went over the statements. We need to assess for those risk questions, which is like, do you have a plan? Do you ever think about it? Do you have means to carry out your plan? We want to make sure we always continue to reassess this. We want to make sure we create a safe environment for the client. We want to make sure that we have no sharps, straps, belts, glass items. We want to make sure that we put they give them the paper plates, utensils that are not metal, no knives. The trash bags have to be the brown bags, not the plastic. Have one-to-one supervision, no private room, keep the door open for the client, make sure that you check their mouth after you give them meds, make sure you round at irregular intervals, you have to screen your visitors because we don't want them bringing in like sharps or anything to them. So it's very important with them. And now we can also, if medications do not work, we can use ECT. So we try to avoid ECT because it has the potential for bad outcomes because it can be invasive. However, it does work for patients with severe depression and bipolar disease if the client the medication's not working for them. So we want to make sure that ECT it uses that brief electric current to enhance the effects of neurotransmitters. We want to make sure that we always give a thorough assessment of the patient. It's going to be given at least once, like every 3 weeks or something like that. You always have to get signed consent. You always want to make sure that you have it, give them the right medications, make sure they have an IV. One thing you're going to want to teach your patient is they're going to have headache, memory loss, and confusion that are going to be temporary after the procedure. So we need to make sure we educate on these things before they go into ECT. Transmagnetic stimulation is not invasive. It uses magnetic pulsations to stimulate the cerebral cortex. It's like ECT, but it doesn't trigger the seizures. Vagal nerve stimulation provides electrical stimulation through the vagus nerve of the brain, uses a surgical implanted device, helps to increase neurotransmitters and enhance effect on medications. So it's usually used for depression. We always want to make sure that we assist the provider in getting informed consent with these things. Hoarseness is going to be a lot of your side effects because it affects your larynx and pharynx. Okay, what else? So it is an effective alternative. However, mood improvement with a lot of your medications is going to take weeks. Okay. Medications. So medications are usually going to be your first line for your depression. So SSRIs. Remember, they block neuronal uptake of serotonin. However, the various ones, fluoxetine, I would be familiar with. But the problem with SSRIs is that it can cause serotonin syndrome. Other problems can be they can have abdominal pain, diarrhea, sweating, fever, tachycardia. They can also have sexual dysfunction And often patients that take an SSRI, they may begin to improve their mood. However, we need to watch for suicide, because suicide is very prevalent after one takes an SSRI because they have energy to do so. So we need to make sure that we always assess for that and assess for serotonin syndrome, because that can be deadly. And these are your symptoms of serotonin syndrome. Next, we can use an SNRI. So SNRIs work the same way as an SSRI, but they block also norepinephrine. So that's all. And now we go on to our favorite medication, MAOI. So MAOI, it increases norepinephrine, serotonin, dopamine. However, we're not going to want to use this medication a lot because it has so many food reactions, and we need to make sure that the patient who takes this medication knows how to properly care for their body while they're taking it. Remember, no aged meats or cheese, figs, avocados, beer, wine while taking an MAOI, because it can cause a hypertensive crisis. And we do not want patients who have tyramine foods on MAOI. Yes, it may help if any other medication is not effective, but we need to make sure they're able to follow those dietary restrictions. Because we don't want them to go into hypertensive crisis. Okay, so again, here are your unsafe foods. I know, it's the favorite aisle at Aldi, but we have to make sure that they stay safe if they take that. Now we have TCAs. So TCAs inhibit norepinephrine, serotonin, and they make more available. All these medications can take longer periods of time for full effectiveness. They cause anticholinergic effects. However, it can be cardiotoxic if they're taking another medication. So one thing we need to look at is orthostatic hypotension, because hypertensive medication will make their blood pressure drop. But TCAs, they're going to make that blood pressure go up. So we need to assess for orthostatic hypotension with TCA use, and we need to teach our patient to change positions slowly and recognize potential indications that they're having cardiac effects from the medication. And I don't know if there's any more things I need to go over. Remember, safety with depressive clients. You can help them do things like get dressed in the morning, help them get dressed in the morning if they're having a self-care deficit. We need to make sure that the family is involved with their care. Make sure they stick to medication adherence. Make sure that you use therapeutic communication with the client. Make sure that you increase their self-esteem. Do assertiveness training. Make sure that you use problem-solving techniques. Make sure that you make observations rather than ask direct questions, which goes along with your therapeutic communication. And yeah. Any questions on depressive disorders? So I'm actually going to stop the recording